It's always a pleasure coming here. I would like to thank Dr. Mullins and Barca for the invitation to speak to you today about functional and cosmetic outcomes in burn rehabilitation. For the purpose of this talk, I have nothing to disclose. So, what are the goals that we have in burn rehabilitation? And when I talk about burn rehabilitation today, I don't just talk about PT and OT. I talk about the team. I talk about the doctor, the nurse, the social worker, the dietitian, the therapist, everybody working together to produce good functional and cosmetic outcomes at the completion of rehabilitation, which may be 2-3 years down the road. So function and cosmesis is what we're going to be talking about. Bear with me a little bit at the beginning of this lecture. There's a bunch of word slides, then we're going to get into the fun pictures and videos. So it's not about survival anymore. We just talked about that. Dr. Fagan just told us it's not about survival. Improvements in medicine and technology led to the what we know now, the 99% TBSA survives. So we save the large burns. Now what? Right? Now rehabilitation becomes crucial. Rehabilitation from the entire team's perspective. It becomes crucial because we have these 99% survive and we have to send them out of the community. We have to reintegrate them back to their communities. So this is what I'm going to talk to you about today. What are functional outcomes first? Functional outcomes are defined results of care focused on the patient's physical ability. When patients receive rehabilitation, what matters to them is how they're able to perform, is the results, their results that matter to them. So it's good for us in burn rehabilitation to share with them some outcomes. And that's what I'm going to show you later, some pictures of, hey, this would happen to you if you do this and this and this. But if you don't, this is going to happen to you. So sharing typical results with our patients help them set realistic expectations. What are cosmetic outcomes? Cosmetic outcomes are the perception of the patient, how good they look at a given time. So in a recent article by Gerber, it's a 25-year literature review to assess burn injury rehabilitation. They found 64 rehab publications. 22 of those involve interventional trials. 9 only use functional outcomes. They also looked at 67 work-related studies. Again, 24 interventional trials, and again, only 9 functional outcome measures. So what we're finding is that less than 1% of rehab research addresses the burn injury. And of that, less than 1% looks at randomized controlled trials to look at outcomes. So how do we measure functional outcomes? Basically, as we grow, as we're born and go along our cycle of development and growing old, function becomes more complicated as we grow. And how do we measure function? We measure function by patients reporting their outcomes to us clinicians, or by us clinicians measuring their outcomes, measuring their performance and physical ability at a given time. What are some predictors of outcomes that we know from the literature? The age of the patient, it's a predictor of how they're going to do. Dr. Palmieri showed us that 3 years after injury, older patients who were discharged to nursing facilities had a 3 times the chance of dying than those who were discharged home, independent with ADLs. Mechanical ventilation, for those who undergo mechanical ventilation, older patients, maybe smaller burns, about 20% TBSA. And range of motion deficits at the time of discharge will predict how they're going to do in inpatient rehabilitation. Total body surface area burn, it's another predictor. Burn depth, the sex, the age of the patient. Any pre-existing conditions are predictors of how patients are going to do functionally later on in life. Pre-existing conditions such as neurological conditions, diabetes, hypertension, psychosis. Psychology here is very, very important. We're going to talk about that a little bit later. Any environmental status, the marital status of the patient. Patients who are young, married, employed, and of higher functioning at the time of discharge to inpatient rehabilitation did better than those who were not married. They were not of higher functioning at the time they went to inpatient rehabilitation. And most lately, location of the burn is very important. When we're calculating, as Dr. Fagan just mentioned, when we're calculating TBSA, we need to indicate where the burn is. And I'm going to show you some example of how that plays a huge difference in rehabilitation. The psychosocial recovery of the patient is very, very important and can predict their recovery. Physical function, physical ability, psychology, they're all interrelated. One affects the other. People out of Australia, they showed us that children whose parents have high anxiety and difficulty coping with the injury of the child, their children they didn't adapt very well to the injury, not good outcomes at the completion of rehabilitation. So what are measures of functional outcomes in burn rehabilitation? The most well-known functional measure is the Functional Independence Measure, the FIM for adults and WIFIM for children. It was developed in 1983. It's an outcome measure that documents the severity of disability and documents medical rehabilitation. It consists of 18 items. There are 2 subscales, 13 motor and 5 cognitive. They are measured on a scale from 1 to 7. The lower the score, the more dependent the patient is at the time of discharge. The higher the score, the more independent the patient is. Maximum score is 126, and obviously it's the minimum score is 18. So a discharge score of a FIM of about 110 or lower is strongly associated with the need of inpatient rehabilitation. Score of about 110 indicates that a patient can go home and most likely they're going to be independent with performing their activities of daily living. What's important here is that every 5-point deficit on this scale correlates with the need of 1 day of rehab, working on mobility and basic activities of daily living. In a study we did with Dr. Herndon, we showed that children at about 2 years after burns, they become independent of their ADLs despite their total body surface area burn. Of course, they achieve that at different intervals. The smaller burns at about 6 months, the medium burns about 12 to 18 months, and children with the severe burns at about 2 years. Children adapt and they become independent. The FIM has demonstrated some validity and reliability in inpatient burn rehabilitation. It is generally recognized as a burden of care tool. It's not really a measure of function, but rather a burden of care. It helps us decide where the patient, what level of care they are and where they should go next. So this next bullet here, Gomez and colleagues from Canada, actually they utilize FIM scores to transfer patients from their inpatient burn unit to their inpatient rehabilitation in the same hospital. And I know this applies to Augusta now with your inpatient rehab unit. And what they're finding, right, is that by using the FIM to discharge patients to their inpatient facility, they freed up beds quickly. The length of stay in the burn unit decreased, and functional independence improved faster. The FIM and the WIFIM have been criticized, though, because they're not very sensitive to burn-related sequelae like the burn scar, amputations that may have been sustained as a result of the 4th-degree burns, and contractures. So there are some issues there. The new tool now that we're using, CMS is telling us now as of October of 2019, for maximum reimbursement, you have to be using this test, the CARE tool. The CARE tool is designed to standardize assessment of patients' medical, functional, cognitive, and social support status across the acute and post-acute settings. So when the patient is about to be discharged to a long-term facility, to a SNF, to home health, to long-term care hospitals, you have to apply this tool in order to get maximum reimbursement. It's no longer the FIM and the WIFIM. Another assessment to measure functional outcomes is the patient observer scar assessment scale, the POSAS as we know it. The POSAS has the observer scale, us clinicians observing the patient performing some type of functional activity, and the patient scale. The patient scale scores pain, pruritus, color, thickness, relief, and pliability. There's some high quality reliability but intermediate validity on this test. But we use it a lot in assessing scars in burn rehabilitation. Then the Vancouver Scar Scale and the modified Vancouver is the most utilized burn scar assessment to this date. However, this is a functional, it's a subjective assessment. It's not an objective assessment of rehab. So it doesn't give us those conclusive results on specific scar characteristics. So the Vancouver Scar Scale will measure pigmentation, vascularity, pliability, and height. There are different subscales that score a maximum score of 13, and basically the lower the score on the Vancouver Scar Scale, the better your scar looks. There are other assessments for scar characteristics. These are the objective measures of any of these scar characteristics that I mentioned a moment ago. However, these are very, very expensive. If you take the list over here and add it up to measure these 4 or 5 scar characteristics, you may need $500,000. And again, nobody has all these at their disposal to measure functional outcomes, and in this case, to measure the scar. But there are good objective measures that you can use to measure any scar characteristic you wish. Other measurements include strength, endurance, cardiovascular assessments, hand grip, pinch, biodex, pulmonary function, as Dr. Herndon taught us when we studied exercise, peak oxygen consumption, the treadmill, the 6-minute walk. Therapists use a lot of this in their assessments of how patients perform on a daily basis. The disabilities of the arm, shoulder, and hand, the DASH and quick DASH specifically, is another assessment to self-report any disability of the upper extremity. And this quick DASH has been validated for burn patients. Now, range of motion. Range of motion is the most utilized tool that we have in the burn unit and in our patients to measure how the patients move, their mobility, their active range of motion, their passive range of motion. But when it comes to measuring functional outcomes, it's not active range of motion of a joint, but rather the composite movement, right? It's a whole bunch of joints to reach and grab something from a cabinet. It's not just the PIPs, the DIPs, the wrist, the elbow, the shoulder. It's all together working to accomplish this functional activity. So when we measure in function, it's not just the joint. So there are some goniometric measurements that have been recently developed by Parry and colleagues. It's an app. You can get it on your phone. It's called the Scar Goniometry app. And I advise, especially the therapist, to go in there and see how we position the patient now with contractures to measure their range of motion, right? Because it's not just the joint anymore. And I'm going to talk more about that in a second. Here we are, the cutaneous functional units, CFUs, as we know them. They relate to range of motion now. These are previously identified fields of skin that are involved in joint range of motion, and they represent potential sites for contracture development. Prior research has identified that skin recruitment is from distances far away from the primary joint of interest. And that's the example I brought a moment ago. For me to reach up here to grab something from the cabinet, I'm recruiting to do this, to pick this up here. I'm really recruiting skin all the way from my hip, all the way up here to perform this activity. So again, it's no longer range of motion of one joint. These are the functional units we're talking about. I want to show you this example of what I mentioned before, that not only TBSA anymore, but the location of the burn is critical. And this is the example right here. What you're looking at here is 20% TBSA, 20% TBSA, right? Same burn, TBSA. But up here, if you look at this burn, the only sustained posterior burns that affect his neck, shoulder, and hips. Those are sites for potential contracture. But if you look down here at this patient who sustained burns to the upper extremities circumferentially, it's about 20%, right? And here you're going to see 84 CFU sites affected. These are 84 sites affected that potentially can lead to contracture, right? So what does this tell us? It tells us that we have to, as Dr. Fagan mentioned, we have to collect data from all different places, TBSA location, to really think of how we're going to treat the patient in the future. So these identified cutaneous functional units directly correlate to range of motion, the skin recruitment to mobilize a joint. Documentation of CFUs by clinicians, doctors, therapists, nurses may help predict which patients are at risk of developing contracture based on burn location within these cutaneous functional units. And they can help us establish rehabilitation priorities. It will help us utilize resources in rehabilitation more appropriately now in the future. The percent of these CFUs that are scarred is predictive in this study of less range of motion achieved within therapy, thereby providing a potential tool for clinicians to predict the recovery of motion after a burn injury, make clinical decisions about treatment, and again, help allocate appropriate resources. I mean, the rehab manager may say to the therapist, for example, this 20% burn is not going to need an hour therapy, maybe 15, 20 minutes, because there are not a potential contractures there. But this therapist here, this patient over here with 20%, you may need about an hour and a half with them. So the resource utilization is it's big when it comes to CFUs now, and it's going to be bigger in the future. So let's talk about some fun stuff we do at the ICU. Dr. Herndon, who is here, has taught me to challenge the status quo in the burn ICU and in burn care. And starting rehab, I'm going to take you through rehab very quickly now, in a few minutes. So positioning should begin immediately to prevent these contractures and deformities. If you don't position the patient appropriately and aggressively at the very beginning, nursing, therapists, everybody who comes in contact with the patient, this is going to happen. This is real. This shouldn't be happening in any burn units in the United States today. So we gotta position the patients appropriately from head to toe to prevent these contractures. And we gotta be aggressive, and we gotta get in there fast, and we gotta work with nursing. Who is there 24 hours a day, every day, entire year? Holiday, rain, shine, snowing, the nurses. And I love nursing. I work with nursing because nursing helps rehab. Therapists work from 8 to 4:30, they go home. Who's there all night long to care for the patients? Who's there all night long to position these patients? Nurses are. So nurses in this group, thank you so much for what you do in burn rehabilitation. So splinting can prevent these contractures. And there is research to show that. Splinting early on. Patient is intubated, patient is trach. Dr. Heiner has taught me to intervene early, splint them early. Position them appropriately with different thermoplastics. But here's a study from 1968 to 2013, a massive amount of data collected, right, that look at the odds ratio of developing contracture and the relationship between that and wearing a splint. And what we looked at is that with high confidence, that if patients are wearing their splints less than 6 months, you can see axilla, elbow, wrist, knee, let's go with axilla, less than 6 months, the odds ratio of developing a contracture is 90%. If you apply splinting 6 to 12 months, that drops to 56%. And if you wear splint more than 12 months, the odds ratio drops to 32. So this is a proof. This is a 40-year study. This is a proof that shows splinting in burn rehabilitation works. And we need to apply it to prevent those contractures and produce these functional outcomes in the future. What are expectations of functional outcomes? Well, look at this slide. This slide for me is very important. For every single day we spend in bed, the patient spends in bed, there is 1 week of rehabilitation required to recover the lost endurance. 1 day equals 1 week. Muscle at complete rest loses 50% of its mass in about a week. 20 days of bed rest, if we keep the patients in bed and we don't mobilize them. 25% decrease in stroke volume and 25% increase in their heart rate. ICU acquired weakness occurs in 25 to 58% of patients receiving mechanical ventilation for greater than 7 days. The incidence of ICU acquired weakness is compounded with sepsis and can be all the way to 100%, kill the patient. So what's important here? The key here is early mobilization, starting from day 1 in the burn center. Intubated patients are walking. They should be walking, right? All this stuff I'm talking to you about now should be applied early in rehabilitation. These people, actually, this is nursing and rehab working together to produce this paper. Early mobility in intubated patients who are critically ill and have traumatic and burn injuries is safe and feasible. That's what they concluded in their study. Early mobility decreases pneumonia, DVTs, as well as airway, pulmonary, and vascular complications. Medical personnel, nursing, physical therapy, everybody working together, right? We need to embrace a culture change. If we're going to change something, if we're going to start getting patients up early, the whole team has to work together. Team stands for together, everybody achieves more. Nurses have got to get together with the leadership. Who is the leader here? Who is the captain of the ship? Is the doctor. The doctor, the nurses, the therapists, the psychologists, the social workers, the nutritionists, the people who clean the floors. Everybody has to get together to develop protocols, to develop guidelines, to produce good functional outcomes at the completion of rehabilitation. And this is key. Working together. Working in silos will never accomplish that. Of course, we need more randomized controlled trials on early mobilization to determine physical activity dosage. We develop specific protocols in rehabilitation. We need more studies to determine long-term outcomes beyond 2 years, 10 years, 15 years, 20 years, to see how, as Dr. Fagan mentioned before, how what we did early on in rehabilitation when the patient came in affects how the patient looks today, 10 years later, 15 years later, 20 years later. So you guys here at JMS have, in Barca, all of your hospitals have an incredible opportunity because of the massive amount of data you have to create these huge databases to study these things in the future. Very, very important. The effects of exercise on burn rehabilitation and functional outcomes. I had the opportunity to spend the best 17 years of my career with Dr. Herndon, who taught me to push the envelope, to work on exercise, to get involved early in burn rehabilitation. And his work over the last 20 years of exercise has showed us that structured exercise programs, Dr. Herndon, Dr. Suman, and their colleagues, they showed us that structured exercise programs will produce functional outcomes at the completion of rehabilitation. Structured physical therapy, occupational therapy, rehabilitation will help decrease surgical reconstruction if you do it early. And these are publications that are out there for you to read. We studied in the young ones, under 7 years of age, how music can affect exercise. And we have a publication. Music and exercise improves range of motion in the young ones. The young ones, because of their problems early on, the young ones with big burns, with their bones fracturing and their mental capacity to understand aerobic exercise and strengthening, we put them through things that are developmentally appropriate. We use music around the burn center. We had parades around the burn center. All the kids were playing different kinds of instruments on their legs if they didn't have arms. On their arms, a lot of exercise with music every day. We found out at the completion of the study that their range of motion increased. Their outcomes were better because we applied age-appropriate activities. They understood what they were doing. They were having fun, and they were playing, and at the same time, they were improving their outcomes. And then lately, 2016 and 2018, we have now developed specific prescriptions for therapy when it comes to strength, endurance, cardiovascular capabilities. So you can go read these publications, and they have specific treatment protocols for all these areas for strength and endurance. I believe that the work of Dr. Herndon is probably the most complete data set that emphasizes the importance of exercise in outputting good functional outcomes at the completion of rehabilitation. And again, I'm not talking about the patient survived, the patient's wounds are closed, the patient gets, I'm talking about 5 years down the road, 10 years down the road. So exercise begins immediately. Should be part of our daily routine. Again, I'm talking about the team here, not the PTOT. We should create purposeful exercise programs. We should set goals and provide feedbacks to our patients on how they're performing at any given time. We should help our patients with psychological services, psychosocial services, to reduce their fear or anxiety about exercise and prepare them to be performing their activities of daily living early. Exercise helps reduce and control edema, maintain range of motion, minimize loss of muscle mass, muscle strength, minimize the risk of pressure ulcers. We don't want to leave patients in bed. We want to rotate them. We're going to get them up. We're going to get them up in a chair. We're going to walk them early on. Exercise will help us prevent pulmonary complications and decrease the risk of developing thromboemboli. So early in the ICU, age-appropriate activities, get the patients to exercise, to actively participate. Active range of motion, we mentioned passive range of motion, the CFUs. 96% now, as Dr. Herndon said, and 99% technically, especially with kids, survives. But look at a patient like this, 97% burn, amputee, starting early in the ICU with tilt tables, right? Tilting the patient all the way to upright, monitoring heart and blood pressure, all that. You know, getting the patient progressively into a different kind of standing frame all the way to playing ball. This patient graduated college, and they live a very functional, productive lives. Maybe it's about 15 years later. So early ambulation in the burn unit. Again, I keep stressing that every 2 or 3 minutes on purpose. So music activity, age-appropriate activities. Music in the ICU, why not? If we can get the patient to, if we can get to stimulate the patient's senses, do it. It works. Look at examples like this. This again goes to tell you how my chief pushed me to get the patients out because we saved lives. Amputee open wounds, right? He said to me one morning, get the patient up. We gotta stand this patient. So I had to figure out something. So burn rehabilitation is about imagination. It's about those goals I mentioned to you about, how we're gonna achieve functional outcome at the completion of rehabilitation and having function in mind all the time. So dress the patient, got foam, cut the foam, set the patient up. Because the patient had to be up for 2 hours, 3 hours, 4 hours a day, I was told. Then one morning he said, walk the patient. Open wounds like that. So temporary prosthetics, got the patient up. It's not walking like we know it. It's a few steps with the help of a bunch of people. But again, this patient is progressive in function slowly. And then one day, we're pretty much closed. And it's time to get up and walking now again with prosthetics. We get the prosthetics, and we're ready to go. We're starting low to establish that balance, right? And then we're gonna progress slowly. This is above knee amputee bilaterally, right? Rehabilitation early, riding a bike. Look at this, this is the most incredible, most difficult exercise, going up the stairs with above knee amputations. And then of course we measure everything. We measure how many steps, for how long, what we do every day, and we record it in the medical record. Very, very important. Activities of daily living. We take this for granted. If a patient can do anything when they're in the ICU, let them do it. If the patient can ambulate 10 steps to go to the bathroom, let them go to the bathroom. Don't put the bedpan under them, right? If they can fit themselves independently or with adaptive equipment, let them do that. Promote these activities, push for those activities, educate the parents, educate the caregivers, let them do it independently. It's not because you don't love them, it's because you want to get them better. That's what you say. So basically, if we don't practice activities of daily living, we're talking about death. You're going to be shocked. Death? What do you mean about death? This is what I mean about death. I mean dressing and bathing. I mean eating. I mean ambulating. I mean toileting. I mean hygiene. If we don't do this, these activities of daily living, if you think about it, they relate to function and functional activity, functional ability of the patient. Dressing relates to active range of motion, strengthening, wound care, eating, nutrition, caloric intake, wound healing, muscle growth, ambulation, cardiopulmonary, circulatory, endurance, balance, toileting, GI mobility, pulmonary toilet, active range of motion, transfers, hygiene, wound care, skin care, appearance, psychological confidence, self-esteem. These are the building blocks for optimal functional recovery. So please practice death to keep from dying. That's a good one. That's a keeper. So inpatient mobility success is the gateway to outpatient functional recovery. And folks, I keep stressing this. Nursing is critical. We need nursing. Without nurses, we can't do this. We cannot do this. Nurses are there day and night, around the clock, all the time. Give your nurses a hug every day and say, thank you for what you do. Now let's talk about the scars, hypertrophic scars. We know about immature scars are very red, raised and rigid, angry, painful, hard, horrible. When the scars turn mature, they become more devascularized, they are more plastic, elastic, and they are decreased in height. So it's important for us in rehabilitation, all of us, the whole team again, to know the stages of the maturation process. We know that it's unlikely for a patient to develop hypertrophic scars if their wounds close at about 2 weeks. If the wound takes more than 3 weeks to close, it is more likely to develop hypertrophic scar. So in general now, for those therapists in here, if you know something, if you know a burn is deep partial thickness burn or full thickness burn or deeper, you know something is going to happen, so don't let it happen down the road. So apply splinting early, apply, scar management techniques early. You know something is going to happen, don't let it happen because it's going to be more expensive for your burn center. You can get the patients out faster. Now we can manipulate these immature scars for about 2 years, sometimes more. Here is an immature scar. Here is a mature scar. When the scar reaches the 3 Ps, I call it, there's nothing I can do in therapy to fix it. I have to send the patient back to the reconstructive surgeons to reconstruct, fix everything they want to fix, and then they will send me the patient back. But we have to know this. We can't just continue to exercise in vain in this case. So how much pressure do we need to depress, minimize hypertrophic scar? That is the big unknown still. It's very controversial. We started pressure garments back in 1971. Dr. Larson, Dr. Silverstein, these are the fathers of pressure garments. Dr. Larson was the chief of staff in Galveston. Dr. Silverstein was in Oklahoma. But they both came up with the idea of pressure garments. One in Oklahoma looking at the undergarment elastic, and they were observing that scars above and below were hypertrophy, but on the elastic, the scars were depressed. The other one was looking at neck splints at that time with Barbara Willis, a famous occupational therapist. And they were looking, when they're removing the neck splint, the scars were depressed. So they found out that pressure had something to do with depressing the hypertrophic scar. But we have not realized any evidence until later, and I'm going to talk about that. But we decided to do these custom-made garments and put them in about 24 to 28 millimeter mercury pressure. Why? Why did we do that? I mean, there's no science behind it. Somebody came up one day and said 24 to 28. There was some reasoning behind it. The reason behind it, I'm sure most of you know this, but capillary pressure is about 25 millimeter mercury pressure. So you want something equal and opposing to keep that hypertrophic scar down. It is very hard to determine how much pressure is being truly applied at any given time. There is research that shows that about 50% of compression is lost in about 1 month in children. So it's very important here to, when you issue pressure garments to patients, bring them back to evaluate them. Don't just give them pressure garments and send them their way, because you need to see how much pressure is applied at any given time. Now we do have some evidence on pressure therapy. Pressure therapy impacts keratinocyte activity and myofibroblast activity. And what Dr. Lai looked is that the percentages of proliferating keratinocytes and myofibroblasts when she put patients in pressure garments, in about 3 months, we see how these keratinocytes and myofibroblast activity is decreasing, as opposed to those patients who didn't receive pressure garments. And we know how keratinocytes and myofibroblast relate to that overabundance, overgrowth, and that collagen synthesis, that spaghetti-like collagen synthesis that causes these hypertrophic scars. So there's some evidence about pressure. We use a lot of silicone gels. What do these do? We theorize that they soften the scar, they enhance scar flexibility, extensibility, they improve the cosmetic appearance of the scar, they reduce itching, redness, and inflammation. But what we know about silicone is that we don't really know the answers yet. It's a theory. The exact mechanism is still somewhat unknown. But we theorize that silicone occludes the scar So it minimizes the transepidermal water loss, right? Anytime you have a scar on the stratum corneum, water will escape through as part of the healing process. By occluding the scar, the brain sends signals down to the injury site saying, hey, everything looks all right. That scar looks normal. We're not losing water. Water carries oxygen, so we're keeping the oxygen tension high, which reverses the hypoxia effect. We're hydrating the scar. And then later research by Dr. Tredget out of Canada shows that about 1 degree centigrade of elevating the heat within the scar, and that's what silicone does, would help increase the collagenase activity and therefore reduce hypertrophic scars by breaking down collagen bundles. So again, this is not 100% science. We're getting very close, but that's the theory. That's why we use these silicone gels. This is a very good article for us rehabilitation specialists by Thomas Masto. This is the guy that showed everything I just described. Like when you have an injury, water escapes, there's confusion down here, collagen bundles, spaghetti-like, hypertrophic scar. Put silicone on top, hydration of the scar, occlusion of the scar, oxygen tension increases, temperature, and then mechanical pressure. So this is for me the formula for managing scars. Right? This is the formula. This is what we need to be doing. Hydration, occlusion, oxygen tension, temperature, mechanical pressure. That is what is going to lead to optimal scar outcome. But there's some more studies that talk about silicone now. This is a study out of California Shriners. And what they're looking at, what they determine in their 10-year retrospective study is that patients who received silicone early, they didn't have as many surgeries as those who didn't, followed, of course, by the other, by massage, pressure, exercise. So they looked at Vancouver's in this study. So a linear regression analysis showed later application of silicone statistically produced worse Vancouver scores. Now here's another research by Dr. Lai that talks about the height of the scar and pressure. Pressure garments. So pressure therapy group, the silicone gel group, and a combination of silicone and pressure together. And she looked at comparing those with the non-pressure and silicone group. And at about 6 months, she's telling us that silicone and pressure alone, silicone alone, are helping the scar height to decrease. The good results. So there's some more evidence about pressure and silicone. So combination therapy is what we want to practice for good outcomes. Silicone, pressure, exercise. Now let's look at some clinical outcomes, right? This is what we need to be telling our patients now. Here is an example of a patient that sustained superficial and deep partial thickness burns, put in garments. Here's the outcome about 12 months. So this is good to have in your clinic and show the burn patients. Say, hey, this is what's going to happen if you wear pressure garments. We think that helps you. No, I don't want it. Well, look at the results. Look at this one. This one is a full thickness burn. This patient had an epileptic seizure, fell into the frying pan. Full thickness burns, grafted, and then was placed in a silicone-lined transparent face orthosis with a mouth component that the therapist fit. So this patient wore this apparatus faithfully, and the outcome is decent, don't you think? But not everybody's going to have these results. These are the very, very good results I want to show you. But there's something in between. So there is improvement. So what does this tell us? There's some research that shows, that published in the Journal Burn Care and Research, that tells us how silicone may affect the scars. May. We don't know the answers yet, but we looked at laser Doppler imagery, and we looked at blood flow when you're applying a silicone mask versus a non-silicone mask. And what we're looking here specifically, is the same patient different times, but up here, right, on the top, is we're looking at lasers after removing a silicone mask versus after removing a non-silicone mask. And what we're finding, again, we don't know what this means, but what we're finding now is that after you remove silicone from a surface, blood flow remains decreased for about 45-50 minutes, as opposed to removing some kind of a non-silicone appliance from any body part. We see blood flow returns in about 5 to 8 minutes. What does this mean? We don't know yet. But these are observations that are made and have been published in the literature. This may lead to, hey, we don't need to wear garments anymore 24 hours a day. We may not need to wear silicones all the time. Who knows? But there's a long-lasting effect of silicone after it is removed from a surface. Silicone and pressure working together. I mean, you can see some outcomes here very, very fast. Putting silicone, stretching, pressure garments on top. Web spaces, good functional outcomes, very, very fast. Again, this goes back to the range of motion, it goes back to measurements, right? Silicone and pressure working together. And remember what I said earlier, to achieve good functional and cosmetic outcomes at the completion of rehabilitation, when a wound closes, you know, we say when a wound heals, but I like to say when a wound closes, because when wounds close, they continue to heal. We know that. So we need to be saying when wounds close, if we know these wounds are deep partial thickness burns or deeper, apply silicone early. So you don't have to go through that face mask process later on, because you know this is going to hypertrophy, so don't let it hypertrophy. This way you save in your hospital tons of money. You know, this may be $100 versus $3,000 to get this fancy face mask later on, and hours of therapy time. So now we know we can predict the outcome. So attack the problem early. Here's another example. This is a cancer patient. Put silicone on them. 6 months later, you can barely see that. This is another study for the doctors here in the group. What we're seeing here is upper and lower lid ectropia. This patient, if we don't do anything with them, most likely they're going to need some kind of intervention by a surgeons later on. So they're progressively losing their eye closure. So this is how they look at night. When we ask the patient during the day, again, this comes from the Shrine in California. When we ask them during the day to forcefully close their eyes, they can. At night, they sleep like this. So what we do, we take these silicones that are a little bit stretchy, we apply them to the upper eyelid, and in this case, the lower eyelid. When the patient is still inpatient, when they're ready to go to bed, we wipe down all the lotions and all the creams and all that, so we allow that silicone to stick. We put it on. The outcome is superb. Right? Maybe we prevented the surgery, but these are things that we need to do early because we know what's going to happen. We know outcomes. Cosmesis and physical appearance. Head and neck burns are associated with long-term patient-reported dissatisfaction with appearance. Adults with head and neck burns demonstrate great dissatisfaction with their appearance and worse mental health outcomes than patients without head and neck. Interventions to address physical appearance, such as rehabilitation and reconstructive surgery, as early as possible, and mental health, cognitive behavior therapy, social skills training are needed for those patients with head and neck burns. But sometimes patients are done with surgeries. They want to move on. So we can use makeup to conceal some of the scars, not just for women, for men. There are therapists today who get trained on this. And the outcomes are incredible. The Phoenix Society for Burn Survivors has done incredible work, videos, training of therapists. They have different programs to output these good cosmetic outcomes for burn survivors. Burn rehabilitation, as I've been mentioning for the last hour, requires the collaboration across all disciplines to produce outcomes. It's not just one or the other. It's all of us working together to achieve the goals, the outcomes. In the future, this is a recent study by Ryan and colleagues. What do we need to do for functional outcomes in the future? We have indeed made significant progress over the last 15 years, 10, 15 years, as far as outcomes go. Cosmetic, we have more work to do. Psychosocial, we have more work to do. But we need to still develop the standardized hand function test for burns. We don't have one. We have about 7 or 8 standardized hand assessments right now. And they show some validity and reliability in function. But there's not a single one that puts everything together for the burn patient. So the future research when it comes to outcomes, functional outcomes, needs to focus on hand function. We need to look at psychosocial function of burn survivors. We need to look at it more in depth. We need to develop instruments for community reintegration, work and school performance of these patients, long after they leave the burn unit. We need to define the pathway to resiliency. We need to continue to define health needs of survivors using large databases. There are large databases by the World Health Organization, by the American Burn Association, by others. But I urge you guys have such an opportunity to develop your huge databases for the future to study outcomes for function and cosmesis. Determine how long-term outcomes are associated with medical interventions that they were done maybe 15 years ago or 20 years ago. Today, we have a great opportunity with improvement in medicine, all these technologies. What are we doing today may affect how the patient looks, or rather, what have we done 20 years ago may affect how the patient looks today, good or bad. But we need to study that more. We need to develop a greater understanding of the mechanisms, impact, and modulation of hypermetabolism, the work of Dr. Herndon over the last 20 or so years. And the genomic response to inflammation by Dr. Tompkins following burns. Now we started understanding what these great surgeons have been telling us. We are extracting some research from what they've done. And we're understanding outcomes and what they mean from early on to later in life. The million-dollar question here. We need to find treatment for HO. We've been talking about this, and maybe 1,000 articles published in the literature about HO. We don't know how to treat it yet, 100% with 100% certainty. We need to focus our research on scar modulation and skin replacements. We have a bunch of vendors here doing great work and showing us all their new technologies, but we need to understand them better and what they mean in terms of functional outcomes. We need to leverage tracking new technologies to standardize our physical rehabilitation intervention techniques, treatments, protocols. We need to objectively and quantitatively define interventions to establish specific dose response for treatment in order to optimize resource utilization and outcomes. So we have done great work as burn rehabilitation professionals, as a team. But we need to do more, and the future is bright when it comes to working together. Not just the industry, not just the medical professionals here, but the industry out there. You need to see everybody as one big team working together to improve the outcomes of the burn survivor. So with that, I want to thank you all for the opportunity to speak to you today. Thank you.